briefly discuss the recent advances in the management of gynecological malignancies with specific focus on targeted therapy and immune therapy in various gynecological malignancies. We can see that if we look at the malignancy distribution in females, around a quarter of malignancy is due to breast cancer, and another quarter, around 25% of malignancies are typical gynecological malignancies, that is cervical cancer, ovarian cancer, endometrial cancer, etc. Dr. Siddharth Mukherjee wrote a book on cancer which he called Emperor of All Maladies, for which he won Pulitzer Prize. And if we look at if we follow the money, if we follow the research money, we can see that cancer indeed is the emperor of all maladies, with 40% of all research expenditure happening around the world is happening in oncology. That is around $80 billion. If we see how therapy has evolved in cancer, in the First World War, we had seen the use of nitrogen mustard as a chemical weapon. And it was seen that all the American soldiers who were involved in distributing this chemical weapon had developed severe bone marrow aplasia. And after seeing this, Dr. Goodman and Gilman thought that they can utilize this molecule, this chemical, to treat cancer. And that's what they did with remarkable success in Hodgkin's lymphoma. And that's how the first therapy for cancers was evolved, that is, chemicals which act against rapidly dividing cells. This is what happened from 1940s to 2000. But 2001 was a landmark year for cancer. We all have heard imatinib, a molecule which specifically targeted tyrosine kinase. It was a molecule which revolutionized treatment in chronic myeloid leukemia and improved survival by a magnitude which was unimaginable in cancer. In 1970s, with chemotherapy, 70% patients used to die. With Gleevec, with imatinib, more than 90% survival for 5 years. Recognizing this targeted therapy approach, Time magazine called this the breakthrough of the century, and it was actually called the magic bullet. Realizing the potential of such targeted therapy, further research underwent in development of further targeted therapies, such as bevacizumab, which are VEGF inhibitors, that is vascular endothelial growth factor inhibitors, and PARP inhibitors, which are molecules which stop DNA damage response. That is, these are molecules which prevent repair of DNA. Another development that happened in oncology is immunotherapy, that is checkpoint inhibitor therapy. Our immune cells are quite capable of finding out cancer cells and killing them, but the cancer cells have evolved and developed checkpoints against our immunity. We can see here that the tumor cell interacts with the T cell. With the PD-L1 and PD-1 interaction, these tumor cells gives the message to the immune cells not to harm it. And the checkpoint inhibitors are these molecules which break this interaction and harnesses the energy of our own immunity to target the cancer cell. And another development that has happened in oncology is taking advantages of the targeted therapy, that is antibody directed, very specific to the antigen, and also harnessing the power of chemotherapy by linking it to the antibody. So here we can see that the antibody drug conjugate is where we have a targeted therapy where we have a target which is on the cancer cell, and we have a payload, just like a missile. There's a payload which is attached, which is the chemotherapy molecule, which is released on the cancer cell. So this harnesses both the power of chemotherapy and the targeted nature of targeted therapy. If we look at the treatment algorithm for carcinoma endometrium, we can see that in stage 3 and stage 4, the addition of immunotherapy molecules durvalumab, dostarlimab, and pembrolizumab has happened. Not only that, in endometrial cancer, we have seen a sea change in treatment which was based first on histopathology, and now we are treating on the basis of genetic markers, where the PROMIS classifier has shown that the disease which is P53 mutated has a worse prognosis, and the disease which is POL mutated or mismatch repair deficient carries a very good prognosis and has a very good responsiveness to immunotherapy. These are various trials which have explored the use of immunotherapy and have shown consistent benefit in endometrial cancer. We can see that immunotherapy, the checkpoint inhibitors, has improved survival in endometrial cancer, stage 3 and 4 endometrial cancer, the deficient MMR type by 70%, and has become the standard of care not only in deficient MMR but also in proficient MMR type of endometrial cancer, along with certain targeted therapies and chemotherapies. If we look at the treatment algorithm for carcinoma ovary, it's no longer only chemotherapy, but it is the addition of targeted therapy, bevacizumab, addition of PARP inhibitors, rucaparib, olaparib, and niraparib as maintenance therapy, which has completely changed the treatment of carcinoma ovary. A peculiar feature of carcinoma ovary is that it has a tendency to recur and it has a tendency to relapse. Typically, in a stage 3 or stage 2 ovarian cancer, we will see more than 50 to 55% of the patients having a recurrence. So maintenance therapy is something that could have really brought us closer to cure. And this is what we have seen with targeted therapy. The targeted therapy bevacizumab, as per GOG-218 trial and the IMSCON7 trials, both have shown that there is a definite improvement in survival in the high-risk stages of stage 3 and stage 4 with the addition of bevacizumab. If we look at the molecular categorization of ovarian cancer, we see that 50% of carcinoma ovary cases have got what we called DNA damage response deficiency. That is these cancers are more prone to response to targeted therapy such as niraparib, olaparib, and PARP inhibitors, because there are two pathways with which DNA damage is repaired. One pathway is already damaged in 50% of cancer ovary patients, whether they are BRCA mutated or some other genetic pathway. And the other pathway is stopped by these PARP inhibitors. And that's the result that we are seeing, that there are many trials which are evaluating the use of PARP inhibitors quite successfully as maintenance. And we can see that in the BRCA mutated arm, we can see that there is a large benefit that we are seeing in these patients, and also in the homologous recombinant deficient tumors. Now there is a consensus among oncologists that all patients of carcinoma ovary who have shown response to platinum-based therapy should receive PARP inhibitors as maintenance. And then we have the antibody drug conjugate, mirvetuximab, which has shown a significant benefit in relapse and refractory setting, that is in the 3rd line and the 4th line setting as well. If we briefly look at the treatment algorithm for carcinoma cervix, immunotherapy pembrolizumab has entered the stage 2 and stage 3 treatment pattern as well, where we are adding pembrolizumab to concomitant chemoradiation as well. And as that happens in oncology, that new drugs first find relevance in stage 4 disease, and then when they have found to be useful and efficacious in stage 4, then they travel up to the stage 2, 3, and then in the new adjuvant setting as well. So now we are seeing that in carcinoma cervix, even in stage 2 and 3 disease, along with chemoradiation, we have seen the addition of pembrolizumab improves overall survival by 23%, and a difference of survival, absolute survival at 3 years was more than 8%. Here, this is the swimmer's plot where we can see at the downside, we can see that the GOG-204 trial has shown that the paclitaxel carboplatin, we had a response of, we had an overall survival for around 1 year, which has now improved to around 3 years with the addition of immunotherapy and targeted therapy. We can see that atezolizumab with bevacizumab has improved survival to an astounding 32 months from 12.9 months. Even in the recurrent refractory setting, that is treatment failed, multiple times failed patients, we can see that the antibody drug conjugate tisotumab vedotin, which specifically targets tissue factor, has got successfully shown survival benefit and has shown that we can improve survival even in these kind of patients who have been failed 3 to 4 times on therapy. So largely my points that I would like to share with you is that in the endometrial cancer we are seeing a complete overhaul of treatment with genetic basis of prognostication and predictive markers are being available. A complete overhaul has happened in endometrial cancer where we are seeing that the staging has been done on the basis of genetic markers. In deficient MMR, we are seeing exceptional response to immunotherapy, while immunotherapy has definitely become standard of care in all stage 3 and stage 4 endometrial cancer. Targeted therapy, bevacizumab, when added to chemotherapy as maintenance, has shown survival benefit, and PARP inhibitors have also shown survival benefit in more than 50% of ovarian cancer. Antibody drug conjugates are showing survival advantage in not only in stage 4 but also in relapse refractory setting as well. Immunotherapy, pembrolizumab has shown advantage when given in addition to chemoradiation, and has shown advantage also along with bevacizumab in stage 3, stage 4, and has become the standard of care. Thank you.
That's excellent clear-cut deliberation, sir. You highlighted about the superior efficacy of immunotherapy and targeted therapy in gynec malignancies in detail. Good, very good.
Thank you.
Nice presentation.
Any questions? How often are you using these therapies now, and how cost-effective are they?
So, ma'am, if you look at the MRP cost of these molecules, they are around 70 lakh rupees for a year of treatment. That is the MRP cost. But then we have some patient support programs where if you purchase one molecule, you get one dose free or something like that, which results in the expenditure, that is out-of-pocket expenditure, to be around 10 lakh rupees for 1 year of treatment. For 1 year of treatment. Yes, ma'am, such a difference. And we are utilizing it quite commonly. Obviously, finance is an issue. This is not something for the IMSCON patients, but we have a good number of patients. Like any given month, we have around 5 or 6 new cases which are entering immunotherapy, and we have around 20-30 cases who are on immunotherapy in a given month. So it has really come up as and become a standard of care. Even in the city of Bhopal, I mean, like in Mumbai, Delhi, it's already.
So thank you very much. And it's so wonderful to see that we are shifting from the cytotoxic treatments to actually targeted.
Yes, ma'am. We are seeing the movement of these molecules from stage 4 to now stage 1 as well. And new adjuvant approach is also going to come for immunotherapy.
I have another question, sir. What about the, do they not have any dangerous side effects because they are immunotherapy?
Yeah, we do have some side effects, but the side effect profile is not like that of chemotherapy, which is dose dependent. We have idiosyncratic side effects, like some patients will develop hypothyroidism, some patients will develop certain immune disorders, some patients will develop certain myocarditis, but those are not very common, and largely the drugs are tolerated very well. I would also like to additionally inform the audience that Zydus has come up with an immunotherapy. So now the first generic immunotherapy is available in India from January 2026. So the price question that you had asked, we will be getting it at 4.5 lakh rupees per annum.
Common side effect when you use chemotherapy is hair loss.
Yes.
And pancytopenia.
Yes.
In immunotherapy, does it happen?
No, ma'am, that is not the side effect profile is totally different. It is more it is more idiosyncratic and not dose dependent. And it is more the more common side effects are like hypothyroidism. And things are quite manageable. In fact, one of the peculiar things about immunotherapy is that we want those side effects. Like if some of my patients develop grade 2 hypothyroidism, I'm very happy. Because if they are developing side effect, that means their immune system is activated, and that means that the drug is definitely going to work. So I would say that if I have given, let's say 60 or 70 odd patients immunotherapy, I have seen one life-threatening side effect, where my patient developed diabetic ketoacidosis, and patient will become autoimmune diabetic for life. So those kind of side effects are seen in immunotherapy. So, ma'am, this is a recent revolution. This was started in 2013 by Jim Allison, and has been in India since 2015 and 2016. The first use case was in melanoma, and if you have heard of the American president Jimmy Carter, he had melanoma which was metastatic to brain, and he survived for another 15 years with stage 4 melanoma because of this molecule. He died last year. Ma'am, deficient MMR, actually, I have a few patients. The response is so remarkable, it is almost guaranteed. And in the PET CT, we see the disease goes from 100 to 0. Like I'm talking about stage 4 metastatic disease.
So have you seen any new malignancies arising in these patients in your practice?
Post immunotherapy as in second malignancy due to, no, immunotherapy does not cause that kind of side effect. Like that is definitely true for chemotherapy. We do see patients who have had exposure to chemotherapy or radiotherapy develop second malignancy, but for immunotherapy, that is not a side effect. In all stage 3, stage 4, that has now become standard of care, ma'am. It is only about affordability that is the issue that we need to discuss. And in India, we are right now innovating for low dose immunotherapy. So those molecules which cost the 200 milligram vial will cost around, let's say 1.5 lakh rupees. But 20 milligram of that dose is being given in India, and it has shown remarkable efficacy.
Will it cause acquired immunodeficiency?
So it does not cause immunodeficiency. In fact, the nature of the drug is that it increases immunity, because we are essentially utilizing immunity. So autoimmune disorders are a cause of worry. If the patient has got autoimmune disorders, then we will be very cautious in our use of immunotherapy.
Thank you so much, Dr.
Thank you.
Aniket. We can go on and on for ages because this is such a new subject for all of us and so very intriguing. So, but then I think we have a little shortage of time. We can take the questions later.